Imagine a patient crashing in an emergency room. They're wheeled through the double doors, pale, tachycardic, and they are actively vomiting blood.
Yeah, it's one of the most terrifying high-stakes scenarios you can face in medicine.
Right. And for decades now, the very first thing a doctor does in this scenario is order a specific, continuous IV drip. It is just pure muscle memory.
Oh, absolutely. The
Hmm.
team scrambles, they find a vein, and they just start pumping this drug into the patient's bloodstream.
Exactly, like before they've even finished taking a medical history. But what if I told you that massive gold standard clinical trials have actually proven this knee-jerk reflex doesn't save lives?
It doesn't even stop the bleeding.
It doesn't.
Mhm.
And it might actually be doing serious harm. So you are in the room with us today for a deep dive into how one of medicine's most deeply ingrained habits is, well, essentially a clinical illusion.
It really is a remarkable story of how, institutional momentum can just completely override empirical evidence.
Yeah.
I mean, we see it happen every single day in hospitals around the world. The drug we're talking about is a proton pump inhibitor, or a PPI. Things like pantoprazole or esomeprazole.
Right, the ones everyone knows.
Exactly. And the condition is a severe upper gastrointestinal bleed. The disconnect between what the actual science says and what happens on the ward is, it's staggering.
And that is our mission for today's deep dive. We've compiled a massive stack of clinical guidelines, systematic reviews, and raw, unfiltered trial data. We're going to deconstruct the dogma surrounding PPIs and upper GI bleeds.
Because we really want to find out if this instinctual drip is a lifesaver or just, a dangerous waste of time and vital resources.
Exactly. Now, before we really dive in, just a quick note on terminology for you listening at home. We're going to be talking heavily about the medications that actually cause a lot of these catastrophic gastric ulcers in the first place.
Yeah, that's a huge piece of the puzzle.
Right, so you'll hear us talk about nonsteroidal anti-inflammatory drugs. But just to keep things moving naturally, we're just going to refer to them by their common acronym, NSAIDs.
Which is super important context because NSAIDs increase the risk of ulcer complications by a factor of 4.
Wow, a factor of 4?
Yeah, and that risk is entirely dose-dependent. So they are kind of the invisible antagonist in the background of this whole medical drama.
Okay, so let's put ourselves right back in that emergency department bay. The patient is bleeding, the team is totally stressed, and the very first intervention, the automatic reflex, is giving a massive dose of a proton pump inhibitor before the patient ever gets wheeled upstairs for an endoscopy.
Right, the pre-endoscopy phase.
Yeah. Now, I want to play devil's advocate here for a second because on paper, this theory sounds beautifully logical.
Oh, it makes perfect physiological sense.
Right, because we know that acid in the stomach breaks down blood clots. It dissolves them. So
Yeah.
the patient is bleeding, they have a clot trying to form over an ulcer, and we give a PPI to neutralize the stomach acid.
Yep, the pH goes up.
Exactly. The environment becomes less hostile, the clot stabilizes, and the bleeding stops. I mean, it sounds flawless.
It's an incredibly elegant theory. The issue, though, is that human beings aren't just, simplified chemistry experiments where you just add a base to an acid and solve the problem.
Right, biology is messy.
It's incredibly messy. If we want to know what actually happens in a living, breathing, crashing patient, we have to look past the theoretical plumbing. We have to look at hard outcomes.
And the ultimate reality check for this pre-endoscopy phase is the Sridharan 2010 Cochrane Review, right?
Yes, exactly.
Let's contextualize that for a second. Because if you're listening to this and you aren't buried in medical literature every day, a Cochrane Review is essentially the Supreme Court of medical evidence.
That is a great way to put it.
They don't run new trials themselves, right? They basically scoop up all the well-conducted randomized controlled trials that already exist on a topic.
Yeah, they mash all that data together, they strip away the bias, and they give us a definitive, mathematically sound answer.
And they are notoriously strict.
Oh, incredibly strict. So this particular Cochrane review looks specifically at PPI treatment that was initiated prior to an endoscopic diagnosis.
So the blind reflex in the ER.
Exactly. And it encompassed 6 major randomized controlled trials, which brought the total patient pool to 2,223 people.
So we're not talking about some tiny, underpowered pilot study here.
No, not at all. This is a very robust, highly scrutinized data set. They compared patients who received active treatment with a PPI, whether oral or intravenous, against a control group.
And what did the control group get?
Well, they either got a placebo, an older, weaker drug like an H2 blocker, or absolutely no treatment at all before they had the camera put down their throat.
Okay, so this is the moment of truth. This drug is the standard of care globally. It's practically an automatic order in hospital computer systems. So if I am the doctor prescribing this, I'm fully expecting to see that it saves lives. I expect to see mortality drop.
Prepare to be disappointed.
Uh-oh.
The results were strikingly, uniformly negative across the board for every single patient-oriented outcome you could possibly care about.
Wait, really? Every single one?
Every single one. Let's look at the actual numbers. Mortality. There was zero clinical benefit. The odds ratio was 1.2.
Okay, let's unpack that number. An odds ratio of exactly 1 means there is zero difference between the two groups, right?
Correct. And anything above 1 actually leans toward the treatment being harmful.
Oh, wow.
Yeah, so at 1.12, the point estimate slightly favored harm, though we have to note it wasn't statistically significant.
What were the raw percentages?
The mortality rate was 6.1% in the group that got the PPI and a 5.5% in the control group that got nothing or a placebo.
Wait, hang on. I wanted to make sure I'm hearing this right. You are telling me that people were slightly more likely to die if they got the standard of care, hospital-mandated PPI.
That is exactly what the data shows.
Even if the math says it's not a huge statistical leap, that is wild.
It is. But let's say mortality is a high bar. What about rebleeding? Did it stop the patients from starting to bleed again after they initially stabilized?
I'm going to guess no.
No. There was zero change. The rebleeding rate was 13.9% with the PPIs and 16.6% with the control.
Okay, what about the need for blood transfusions? Did it at least save the blood bank some stress?
Nope. No change there either. And perhaps most critically, did it prevent the patient from deteriorating so badly that they needed emergency surgery to stop the bleeding?
Please tell me it did that, at least.
Absolutely no change. 9.9% of the patients in the PPI group ended up on the surgical table. And in the control group, 10.2%.
That's essentially identical.
The authors of the review looked at this mountain of data and literally concluded that there is no evidence, none, that PPI treatment prior to endoscopy affects any clinically important outcome.
I am genuinely baffled by this. If you're listening, I really want you to hold on to that 6.1% mortality rate for the PPI group. We have a medical intervention performed thousands upon thousands of times a day across the planet.
Yeah, every single day.
And the gold standard of evidence, dating all the way back to 2010, says it does absolutely nothing to save the patient. Nothing to stop the bleeding, nothing to keep them away from the surgeon's knife.
Exactly nothing.
So I have to ask, how on earth does a practice survive this kind of damning data? Is it just defensive medicine? Like fear of being sued if you don't do what everyone else is doing?
Well, defensive medicine definitely plays a role in the culture, certainly.
Yeah.
But the true root of the problem lies in how clinical trials can be creatively interpreted.
Ah, creative interpretation.
Yeah, or given a highly polished positive spin. To understand the dogma, we really have to look at the foundational trials that built it. We need to dissect the Lau trial and the Dineshman trial.
Okay, let's tear them apart. Start with the Lau trial. Paint the picture for us.
So we're looking at a study published in 2007. This was a double-blind, randomized controlled trial run out of a single major hospital in Hong Kong. They enrolled 638 patients who came in with overt, obvious upper GI bleeds. They randomized these patients to either receive a high-dose IV omeprazole drip or a placebo drip.
Makes sense.
Now, here's the critical detail. When the researchers originally designed and registered this trial, their stated primary outcome, the main thing they were setting out to prove, was mortality.
They wanted to prove the drug saved lives.
Exactly.
But based on what you just told me about the Cochrane review, I'm guessing they failed.
They failed completely. There was no statistical difference in mortality. It was 2.5% with the PPI and 2.2% with the placebo.
So again, technically slightly higher with the drug, though probably not statistically significant.
Right. But, researchers are under immense pressure to publish, and medical journals love positive results.
Right. Nobody wants to publish a study that says we tried a thing and nothing happened.
Exactly. So when the manuscript was finally published, the focus mysteriously shifted. They published the paper highlighting a secondary outcome as if it were the main event.
Oh, wow. What did they focus on?
They focused on the need for endoscopic intervention. And there, they did find a difference.
Okay.
19% of the patients on the PPI drip needed the gastroenterologist to actually do something during the scope-like inject epinephrine or place a clip.
Compared to what in the placebo group?
Compared to 28% of the placebo group.
Let me make sure I'm hearing this right. They didn't save any lives. They didn't prevent anyone from needing surgery later. They didn't reduce the total number of blood transfusions required.
Nope.
Every single metric that actually matters to the human being in the bed was negative. But because the doctor performing the scope had to do slightly less physical work during a 10-minute procedure, the trial was hailed as a success.
You've hit the nail on the head. In evidence-based medicine, we call this a disease-oriented outcome, or in this specific case, a doctor-oriented outcome.
A doctor-oriented outcome. That is brutal.
It is, and it is fundamentally different from a patient-oriented outcome. And, this isn't an isolated incident either. We see the exact same psychological trap in the Daneshmand trial, which goes all the way back to 1992.
Okay, tell me about that one.
This was an absolutely massive study. It involved over 1,100 patients across 2 large hospitals in England. They gave an IV omeprazole bolus followed by intermittent doses and pitted it against a placebo.
And let me guess, the results were the same as smoke and mirrors.
Even worse, arguably. The authors of the Daneshmand trial explicitly concluded themselves that omeprazole failed to reduce mortality, failed to reduce rebleeding, and failed to reduce transfusion requirements.
Wow, they actually admitted it.
They did. In fact, the mortality trended worse again. 6.9% in the PPI group died versus 5.3% in the placebo group.
There is that trend toward higher mortality again. That is terrifying when you consider the scale at which this drug is given globally.
It really should give any clinician pause. But despite all those negative clinical outcomes, they found one single isolated statistical difference.
What was it this time?
They looked at the visual signs of bleeding seen during the endoscopy, what gastroenterologists call the stigmata of recent hemorrhage.
Stigmata of recent hemorrhage. Sounds dramatic.
Well, 33% of the patients who got the PPI had these high-risk visual signs, compared to 35% in the placebo group.
Okay, so when the specialist goes in with the fiber optic camera, the stomach environment just looks a little bit cleaner.
Exactly. There's less active oozing. There are fewer large, frightening visible blood clots for the doctor to look at.
Okay, let me try an analogy here to ground this, because this distinction between what the doctor sees and what the patient actually experiences is crucial.
Go for it.
Imagine you have an old, beaten-up used car. The frame is completely rusted out, the engine is failing, it's a total disaster.
Okay.
Now, you take a can of glossy spray paint and you just paint right over the rust spots. When the mechanic walks up and takes a first glance, the car looks vastly better. It's aesthetically pleasing.
Right. It looks like a decent car.
That's what the PPI is doing pre-endoscopy, right? The endoscopist goes in, they see less blood, they feel a sense of relief, they maybe have to deploy fewer metal clips. But painting over the rust doesn't actually stop the car from breaking down on the highway at 70 miles an hour.
No, the engine is still dead.
Right. Giving that PPI drip in the ER doesn't stop the patient's biological systems from crashing. They still require the same massive amount of blood products. They still end up rushing to the operating room for surgery at the exact same rate, and they still die at the exact same rate.
Exactly.
We're literally treating the doctor's visual comfort, not the patient's life-threatening crisis.
That analogy is brilliant because it captures the illusion perfectly. The paint doesn't fix the structural integrity of the car, and the pre-endoscopy PPI doesn't fix the structural integrity of the bleeding artery.
It's just cosmetic.
Yeah, the only thing it reliably does is reduce the stigmata of recent hemorrhage. It makes the procedure slightly less stressful for the specialist, but it does absolutely nothing to change the trajectory of the patient's survival.
And yet, this practice has burrowed so deeply into the culture of emergency medicine that to question it on the ward often invites strange looks.
Oh, you'll get more than strange looks. People will think you're crazy for not ordering it.
What fascinates me is how the highest levels of medical authority look at this exact same data and come to wildly different conclusions based on their own cultural inertia.
The guidelines are a perfect example of this.
Right, let's look at the guidelines. If you fly over to the United Kingdom and look at their National Institute for Health and Care Excellence, the NICE guidelines, they are incredibly strict.
Very strict.
They looked at the street heron data, the Lao data, the Daneshmand data, and they drew a hard line in the sand. They explicitly state, and I quote, "Do not offer acid suppression drugs before endoscopy to patients with suspected nonvariceal upper gastrointestinal bleeding."
It is black and white. Do not do it.
Right. They recognize that an intervention without a patient-oriented benefit is an unnecessary intervention.
Exactly. But then you cross the Atlantic.
Right. You read the guidelines from the American College of Gastroenterology, the ACG. They have access to the exact same Cochrane reviews. They see the exact same lack of a mortality benefit. And yet, They give what can only be described as a lukewarm, highly conditional recommendation that just keeps the dogma alive.
It's so frustrating.
What do they actually say in the ACG guidelines?
They state that PPIs may be considered to decrease the proportion of patients who have high-risk stigmata at endoscopy.
May be considered.
Yeah. And they openly admit in the very next sentence of their own guidelines that PPIs do not improve actual clinical outcomes like further bleeding, the need for surgery, or the risk of death.
But by saying it may be considered, they leave the back door wide open.
Wide open. They provide institutional cover for doctors to keep doing it just to make the scope visually easier.
It is an incredible study in human psychology. The guidelines are essentially saying, we know it doesn't save the patient, but it makes the specialist's Tuesday afternoon a little bit smoother, so, go ahead.
That's practically a direct translation.
So, if you are a listener out there, perhaps a medical student or a curious patient, the absolute takeaway for this first phase of the emergency is crystal clear. Flying blind in the ER with a PPI drip before a camera goes down the throat is an illusion.
It paints the rust, but it does not save lives.
That is the definitive bottom line for the pre-endoscopy phase. But the story of this drug isn't over, is it? We have to follow the patient to the next stage of their care.
Right. We can't just stop at the ER doors.
So let's transition. The patient survives the initial chaos of the emergency department. They get wheeled upstairs into the endoscopy suite. The gastroenterologist goes in with the camera, navigates through the stomach, and they actually find the source of the leak. Let's say they find a bleeding peptic ulcer, which is incredibly common, accounting for roughly 50 to 79% of all these upper GI bleed cases anyway.
Very common.
The doctor gets to work. They use thermal coagulation to burn the vessel shut. They deploy microscopic metal endoclips to pinch the tissue together. They inject epinephrine to constrict the surrounding blood vessels.
They achieve mechanical hemostasis.
Right, the leak is officially plugged. Now, the scope comes out. What happens after the procedure? We obviously aren't just sending them back to a recovery ward with a pat on the back. Does the math finally change here? Does the PPI earn its keep once the mechanical fix is in place?
Yes, it does. This is the pivot point where the narrative shifts from medical illusion to actual pharmacological benefit.
Oh, thank goodness.
Yeah. Once the specialist has visually identified a bleeding peptic ulcer and has mechanically stopped the bleeding with clips or thermal energy, starting a strong PPI therapy post-endoscopy demonstrates a very real, tangible clinical benefit.
Okay, I'm so relieved to hear the drug actually works at some point.
Yeah.
But let's be precise. What are the proven benefits? What are we actually achieving by suppressing the acid now?
Well, to understand the benefit, we turn to the Sung 2009 trial, as well as broader Cochrane meta-analyses that focus exclusively on post-endoscopy PPI use.
Tell me about the Sung trial.
The Sung trial was a rigorous, randomized, multi-center, double-blind study involving over 700 patients. After the endoscopists successfully achieved hemostasis, meaning they stopped the bleeding, the patients were randomized.
Okay, what were the groups?
One group received a massive IV esomeprazole bolus, followed by a continuous infusion for 72 hours. The other group received a placebo.
And the wins here were actually real.
Very real and highly significant. First, there was a profound decrease in recurrent bleeding.
How profound?
In the Sun trial, the patients who only got the placebo had a rebleeding rate of 10.3%. The environment in their stomach was still highly acidic, which was actively dissolving the fragile clot the doctor just formed.
Right, the acid is literally eating the scab.
Exactly. But in the esomeprazole group, the rebleeding rate plummeted to 5.9%.
Wow. That is nearly cutting the risk of rebleeding in half. That is not a marginal difference. That is a massive clinical win for the patient.
It changes the entire recovery trajectory, and the downstream effects are just as impressive.
I would imagine so if they aren't bleeding again.
Yeah, because the rebleeding rate dropped so dramatically, the need for endoscopic retreatment, meaning rushing the patient back down to the suite to shove the camera down their throat, a second time decreased from 11.6% in the placebo group down to 6.4% in the PPI group.
Nobody wants to get scoped twice in one day.
Nobody. And most importantly, it severely decreased the need for emergency surgical intervention, dropping from 5.4% down to 2.7%.
This goes back to your point about the environment. Once the mechanical clip is on, if you suppress the acid, you give the ulcer a fighting chance to biologically heal without the gastric juices constantly eating away at the scab.
Precisely. You are protecting the mechanics work.
Okay, so less bleeding, less repeat scoping, and significantly less surgery. That is a fantastic profile. I have to ask the ultimate question, the one we keep coming back to.
I know what you're going to ask.
Does all of this finally translate to lower mortality? Do we actually save human lives by giving the PPI after the scope?
You have just walked us right into one of the most baffling, counterintuitive mysteries in the entire field of gastroenterology.
Oh boy.
It is known as the Asian versus Western mortality paradox.
A paradox. Okay, I am entirely ready for this. How can a drug that halves the surgical rate have a paradoxical mortality outcome?
It requires looking at the data geographically. When researchers take all the randomized trials on post-endoscopy PPIs and separate them by where in the world the study was conducted, a stark and frankly shocking contrast emerges.
Okay, let's break it down.
Let's look at the trials conducted in Asia first, like the Sung 2009 trial we just discussed, which was run in Hong Kong. In these Asian populations, there is a clear, definitive, statistically significant decrease in overall mortality.
So it works.
Yes. The patients who received the post-endoscopy PPI had a mortality rate of just 1.5% compared to a 4.4% mortality rate in the placebo group. The drug clearly, mathematically saves lives in Asia.
A clear, undeniable victory. So what is the paradox?
The paradox appears when you look at the exact same clinical trials conducted in non-Asian countries, what we broadly categorize as Western trials, done in Europe and North America.
And what happens there?
In these populations, the mortality benefit completely vanishes. It evaporates.
Wait, really? It just disappears?
It gets worse. The data shows that mortality actually looks higher when you give the PPI.
Higher.
Yeah. In these Western populations, the mortality rate was 4.8% for the patients receiving the PPI, compared to only 3.6% for the patients who got the placebo.
Wait, stop. I need to make sure I'm understanding this. We are talking about the exact same medication, right?
The exact same chemical compound.
Given for the exact same medical emergency, a bleeding peptic ulcer. And you're telling me it saves a life in Hong Kong, but it statistically increases the chance of death in Sweden or the United States.
That is exactly what the data implies.
How is that biologically possible?
Yeah.
A stomach is a stomach. An acid pump is an acid pump. Is it the water? Is it the diet? Is there a massive difference in how the drug is dosed?
It defies basic mechanical logic until you step back and look at pharmacogenomics, epidemiology, and the subtle differences in how human populations have evolved.
Okay, you're going to have to explain that.
We have to move past the simple plumbing of the stomach. Let's talk about why this might be happening. The most prominent theory centers around genetic differences in drug metabolism, specifically a hepatic enzyme called CYP2C19.
CYP2C19. Okay, for those of us who haven't taken biochemistry in a decade, what exactly is a hepatic enzyme and what does this specific one do?
Sure. Your liver is your body's primary detoxification factory. It uses a family of enzymes called cytochrome P450 enzymes to break down and clear out foreign chemicals, including medications.
Okay, so they're like the cleanup crew.
Exactly. CYP2C19 is a specific liver enzyme responsible for metabolizing and clearing proton pump inhibitors out of your bloodstream.
Got it.
Now, here's where the genetics come in. Due to evolutionary biology, a very significant percentage of the Asian population possesses a genetic variant that makes them what we call poor metabolizers of CYP2C19.
Meaning what?
Their livers simply do not produce enough of the active enzyme, or the enzyme they do produce is sluggish.
So their bodies can't clear the drug as fast as a Western patient.
Exactly. It clears at a drastically reduced rate. In a normal metabolizer, the half-life of a PPI, the time it takes for half the drug to be eliminated from the blood, is roughly 1 hour.
Okay, 1 hour, pretty fast.
But in a poor metabolizer, that half-life can stretch to 3.5 hours, sometimes up to 10 hours.
10 hours.
Yeah. Because the drug stays active in their systemic circulation for so much longer, they effectively receive a massive, sustained, highly potent dose of acid suppression compared to a Western patient who is taking the exact same physical pill or IV drip.
Oh, wow.
They get a vastly exaggerated pharmacological effect.
So because of their genetics, they are essentially marinating in the drug, getting a hypersuppressive effect that protects the ulcer incredibly well.
That is the leading theory. But, it's not just genetics. There are also deep epidemiological differences.
Like what?
For example, differing regional rates of Helicobacter pylori infection. H. pylori is the bacteria that causes a huge percentage of these ulcers. The prevalence of this bacteria is generally much higher in Asian populations.
Okay.
Furthermore, the underlying baseline health of the patients might differ. Western patients in these trials tend to be older heavier, and carry a much higher burden of cardiovascular comorbidities.
Or maybe they're bleeding because they're taking massive amounts of NSAIDs for arthritis rather than having a bacterial ulcer.
Exactly. The cause of the bleed might be fundamentally different.
Yeah,
But
no.
here's the most critical, sobering point for you listening. Despite this fascinating regional variance, when you pool all the global data together into one giant meta-analysis,
Yeah.
the overall global mortality benefit of giving a PPI post-endoscopy washes out to effectively zero.
Zero. All those prevented surgeries, all those stabilized clots, and the net global impact on human survival is a wash.
It is a wash. I mean, it prevents rebleeding, absolutely.
Yeah.
It prevents repeat surgeries, yes. But it does not definitively save your life overall.
That is just wild to me.
And to truly grasp the dark side of this paradox, to understand why mortality might actually go up in the West, we have to talk about the Hasselgren trial.
I am almost afraid to ask, what happened in the Hasselgren trial?
This was a major, multi-center trial conducted across 29 different hospitals in Sweden and Norway.
Okay.
They were looking specifically at patients over the age of 60 who came in with bleeding peptic ulcers. They randomized these older Western patients to either receive a high-dose IV omeprazole continuous drip or a placebo drip.
Okay, standard setup.
This trial was highly anticipated in the gastroenterology community, but it never finished. It had to be abruptly stopped early by the Safety Monitoring Board.
Stopped early. Usually in medical news, a trial is stopped early because the drug is working so incredibly well that it becomes ethically impossible to withhold it from the placebo group. Is that what happened?
Quite the opposite. It was stopped early for severe safety reasons.
Oh, no.
The independent data monitor saw a large, highly alarming increase in 21-day mortality in the group receiving the omeprazole.
How bad was it?
The mortality rate for the patients receiving the continuous PPI drip was 6.9%. The mortality rate for the patients getting the placebo was just 0.6%.
Whoa. Let me just repeat that for the listener. 6.9% of the patients on the standard of care drug died, compared to 0.6% on the placebo.
Yeah.
That is not a minor statistical blip.
Yeah.
That is a massive screaming red siren of harm.
It is a terrifying signal. Now, we must be scientifically rigorous,
Yeah.
This is just one trial, and we shouldn't base all of medicine on one aborted study.
Right, of course.
But when you combine the Hasselgren disaster with the overall Cochrane data showing that general trend toward higher mortality in non-Asian countries, it forces us to confront a very complex, uncomfortable reality.
Which it is.
PPIs are not the benign, harmless magic water that we so often treat them as in the hospital. They have profound systemic physiological effects.
But how does suppressing acid kill someone? I mean, 6.9% mortality. What is the mechanism of death if it's not the bleeding?
It comes down to understanding what stomach acid actually does for you. We view acid as the enemy in an ulcer. But stomach acid is actually a vital component of your innate immune system.
Right, it kills bugs.
Exactly. It is an incredibly harsh, highly acidic chemical barrier that destroys almost all the bacteria and pathogens you ingest. When you put a critically ill elderly patient on a massive continuous PPI drip, you completely wipe out that acid barrier.
The pH goes way up.
The pH of the stomach rises to a level where bacteria can suddenly survive and flourish.
So you are basically turning off the body's natural water filtration system.
Exactly. And in a hospital setting, which is teeming with dangerous pathogens, that is a lethal vulnerability.
Oh, because they catch something else.
Yes. PPI use in critically ill patients has been strongly associated with a vastly higher risk of developing hospital-acquired pneumonia.
How does that happen?
The bacteria grow in the neutralized stomach, migrate up the esophagus, and are aspirated into the lungs.
That is terrifying.
Furthermore, wiping out the acid alters the entire microbiome of the gut, making patients highly susceptible to Clostridium difficile infections, C. diff past, which causes catastrophic diarrhea and can easily be fatal in an older patient.
So if I'm trying to synthesize this entire wild paradox, in Asia, because of the CYP2C19 genetic variant and perhaps the higher rates of bacterial-induced ulcers, the intense acid suppression tips the scales heavily towards stopping the bleed and saving the life.
Yes.
But in the West, where patients might clear the drug faster, but are older, have more heart disease, and are incredibly prone to hospital-acquired infections, that same acid suppression completely destroys their immune barrier.
Exactly.
And the resulting cascade of pneumonia and C. diff infections ends up killing more patients than the bleeding ulcer would have. It perfectly offsets the benefit of stopping the leak.
That is a phenomenal, nuanced synthesis of the current evidence. It is a delicate, deadly balancing act. The key takeaway for the clinician on the floor is this. While we absolutely should give PPIs after an ulcer is confirmed by endoscopy to prevent the trauma of rebleeding and surgery, we must forcefully strip away the illusion that we are administering a miracle, risk-free, life-saving drug.
Right, it's not magic.
We aren't. We are trading one set of risks for another.
Which brings us perfectly to the next crucial question. If we are going to use this drug post-endoscopy, and we know it carries systemic risks, the actual physical administration of the drug becomes paramount. The dosing dogma.
Yes, the how is just as important as the why.
Because even if we accept the benefit of reducing rebleeding, we desperately need to talk about how we are physically putting this chemical into the patient's body.
Absolutely.
You mentioned earlier that the Hasselgren trial used a continuous live drip. The Lau trial used a continuous live drip. The standard classic regimen that is beaten into the heads of medical students in every textbook is a very specific formula, right?
Yeah, it's very specific. Give an 80 milligram intravenous bolus, push it fast, and then immediately follow it up with an 8 milligram per hour continuous IV infusion.
Running non-stop on a pump for 72 straight hours.
Yes, 3 full days.
It requires dedicated equipment, dedicated nursing time, and it permanently ties up a vein. Do we really actually need that complex line-hogging drip?
The short, definitive answer, based on the highest levels of evidence, is a resounding no. And the data backing this up is bulletproof.
Okay, let's hear the data.
To understand why, we have to look at the SACHAR 2014 meta-analysis. This was a massive undertaking that pooled 13 different randomized controlled trials.
What were they testing?
What they did was pit the traditional complex continuous infusion directly against a much simpler method called intermittent bolus dosing. And the results completely, utterly dismantled the need for a drip.
Okay, let's make sure everyone understands the two sides of this fight. We know the continuous infusion, the 80 milligram hit, then the slow 8 milligram drip for 3 days. What exactly is the intermittent bolus regimen?
An intermittent regimen is beautifully simple. You give the patient that initial 80 milligram IV loading dose when they are diagnosed.
Okay.
And then, instead of hooking them up to a machine, a nurse simply walks into the room twice a day and pushes 40 milligrams of the drug through the IV line. That's it.
That's it.
Every 12 hours, a quick push. No complex drip rate calculations, no infusion pumps beeping in the middle of the night, no tying up the patient to an IV pole so they can't walk to the bathroom, just a bolus twice a day.
And when the SACHAR meta-analysis pitted the complex drip against the simple twice-a-day push, who won?
It was a dead heat, which means the simple push wins by default. They found that the intermittent regimen is completely, unequivocally non-inferior to the continuous infusion.
Meaning there's no difference.
Let me be perfectly clear. There's absolutely zero statistical difference in any clinically meaningful outcome. There is no difference in the rate of the ulcer rebleeding. There is no difference in the mortality rate. There is no difference in the total number of blood transfusions the patient requires. And there's no difference in how long the patient has to stay in the hospital.
So all that extra effort for the drip is just wasted energy.
Worse than wasted, actually. In fact, an earlier study done by Andreoli in 2008 actually found that patients who were tethered to the continuous drip had a prolonged hospital stay of greater than 5 days compared to the intermittent group.
Let me guess, simply because they were physically tied to a machine and harder to discharge or mobilize?
Exactly. It's hard to go home when you're chained to an IV pole.
Okay, I want to try an analogy here because when you look at the biology of how this drug works, the idea of a continuous drip just seems bizarre.
Let's hear it.
Let's think about watering a houseplant. Imagine the soil in the pot represents the millions of tiny acid-producing pumps lining the patient's stomach.
Okay, I'm with you.
Now, if I take a massive, giant cup of water and dump it all into that pot at once, that represents our 80 milligram loading bolus. The soil becomes completely 100% saturated. It's just totally waterlogged.
Right.
It physically cannot absorb another single drop of water. Any extra water just pools uselessly on the top.
Right. The system's capacity is totally maxed out. It
Yeah.
cannot take any more input.
Exactly. So once that soil is utterly saturated by the big cup, setting up a highly complex, slow, expensive mechanical drip system to continuously drip tiny microscopic droplets of water onto that already wet soil isn't going to make the plant grow any faster.
No, it won't.
It's not going to make the soil any wetter. It's totally redundant. The soil is already saturated. The pumps are already blocked. It makes infinitely more sense to just wait until the soil starts to dry out a bit, say 12 hours later, and then just dump another full cup of water on it to saturate it again.
I love that analogy because it aligns perfectly, almost identically, with the actual molecular pharmacodynamics of how proton pump inhibitors function.
Oh, really? Tell me about the molecular level.
It is a masterclass in why we shouldn't rely on intuition over biology. What is fascinating here is the precise mechanism of action. PPIs are what we call prodrugs.
Meaning they aren't active right away.
Exactly. When they enter the bloodstream, they are inactive. They have to travel through the blood and physically accumulate in the highly acidic, microscopic space inside the stomach's parietal cells.
Okay.
Only when they hit that extreme acid do they become activated. And once activated, they bind irreversibly to the hydrogen-potassium ATPase pump. They don't just temporarily block the pump, they permanently break it. The protein is destroyed.
So once the pump is chemically broken by the drug, it is dead forever.
Exactly, it's dead. Now, the PPI drug itself only has a half-life in the bloodstream of about 1 single hour. Your liver clears it very quickly.
Okay.
But because it irreversibly destroyed all those acid pumps, the biological duration of action lasts for about 48 hours.
Wait, why 48 hours?
Because that is exactly how long it takes the human body to manufacture brand new, fresh ATPase pumps from scratch.
Oh, this is making so much sense now.
Right. So your massive 80-milligram bolus comes in, it completely wipes out and destroys all the active acid pumps in the stomach, and then the drug is entirely gone from the patient's blood within an hour or two.
So the continuous drip.
Hanging a continuous IV drip for the next 71 hours is sheer folly. You are pumping a drug into a biological system where all of its targets have already been eradicated. The drug has literally nothing to bind to.
Wow, it just floats around uselessly.
Exactly, until new pumps are slowly synthesized. That is precisely why pushing a new dose every 12 hours to catch the newly formed virgin pumps makes so much more physiological sense than a continuous non-stop drip.
It is stunning how a fundamental misunderstanding of cellular biology led to a global nursing protocol.
It really is.
And the clinical takeaway here is massive. The complete lack of a dose-response relationship, the proven fact that pounding the patient's system with a nonstop drip does absolutely nothing more than a simple twice-a-day push further proves our central thesis.
Which is that PPIs aren't the magical dose-dependent bullet we thought they were.
Right. You can't just crank up the dial on the infusion pump and get a better survival result.
Precisely. If it fundamentally does not matter how the drug is given, or how continuously the tissue is exposed to it, it tells us that the drug's role in the overall survival of the patient is marginal at best. It's a supporting actor, not the star of the show.
But I want to talk about the practical, logistical implications of this for a moment, because if you are listening to this and you work in a hospital, you know that an IV line is pure gold.
Oh, absolutely. It's precious real estate.
When you use an intermittent bolus, you instantly, permanently free up a precious IV line. Imagine you are in the ER. You have a patient bleeding out. Their blood pressure is crashing. Because they are in hypovolemic shock, their peripheral veins are collapsing.
It's incredibly hard to get access.
The nurses might only be able to secure 1, maybe 2 good IV lines. In the middle of a massive resuscitation, tying one of those critical lines up for 72 straight hours with a completely useless continuous PPI drip is not just ignoring the evidence, it is a catastrophic logistical failure.
I couldn't agree more.
Which brings us to the most important part of this entire discussion, the true VIPs.
Yes. This is where we shift from dismantling what doesn't work to emphasizing what absolutely definitively must happen to save the patient's life.
Exactly. We've just freed up an IV line by throwing that continuous PPI drip in the garbage. We have an open port. In those chaotic, critical first minutes and hours of a massive upper GI bleed, what medications actually do deserve to go into that line?
Let's reprioritize the resuscitation based on actual hard evidence of survival.
Okay, let's hear the list.
Let's outline the true pharmacological priorities.
Yeah.
And spoiler alert, based on everything we've just discussed, the PPI is going to end up dead last on this list.
Naturally.
Priority number 1, the absolute undisputed VIP of this scenario, is an antibiotic. Specifically, a third-generation cephalosporin like ceftriaxone.
Wait, what?
But there is a caveat. This is specifically for patients who have cirrhosis of the liver who come in with a bleed.
Okay, I have to stop you there and push back hard on behalf of every layman and junior doctor listening.
I figured you would.
Put yourself in the room. A patient is literally vomiting blood into a basin. They are exsanguinating. The monitors are alarming. And you are telling me that your number 1 absolute top priority intervention is an antibiotic.
Yes.
That sounds utterly insane. We're dealing with a massive plumbing problem, a blown pipe. We are not dealing with a sinus infection or a pneumonia. Why on earth are we giving an antibiotic for a hemorrhage?
It sounds counterintuitive until you understand the unique, fatal pathophysiology of a cirrhotic patient. You have to understand what actually kills them.
Okay, explain it to me.
Yes, the acute blood loss is incredibly dangerous and must be managed with transfusions. But shockingly, many cirrhotic patients do not die from exsanguination.
Really?
The bleeding might stop on its own, or the endoscopist might stop it. What actually kills them is what happens in the 3 to 5 days after the bleed.
What happens?
The liver is essentially a giant filter. In cirrhosis, that filter turns to hard scar tissue. Blood can't flow through it, so pressure backs up into the veins of the stomach and esophagus, creating the varices that burst and bleed.
Right, the pipes burst from the
But it also
trachea.
causes the wall of the intestines to become congested and highly permeable. Now, at a massive GI bleed, the intestines fill with pooling, stagnant blood. Blood is an incredibly rich nutrient source for bacteria. The bacteria naturally living in the gut multiply rapidly in this blood, and because the gut wall is weakened and the cirrhotic patient's immune system is severely compromised, these bacteria translocate.
Translocate.
They literally cross through the wall of the intestine and enter the bloodstream and the acidic fluid in the abdomen.
Oh, wow. So the bleed is just the match that lights a massive fire of systemic infection.
Precisely. The patient develops spontaneous bacterial peritonitis, they go into rampant sepsis, the remaining organs fail, and they die. They survive the bleed only to die of the infection caused by the bleed.
That is incredibly tragic.
It is. And the clinical data supporting this intervention is arguably the strongest in all of gastroenterology. A landmark 2010 Cochrane review found that giving prophylactic antibiotics like ceftriaxone to cirrhotic patients with an upper GI bleed reduces bacterial infections, reduces the chance of the varices rebleeding, drastically reduces hospital length of stay.
And does it save lives?
And, most importantly, it significantly reduces overall mortality. The math is staggering.
Give me the numbers.
Let's talk about the number needed to treat, or NNT. It's a metric we use to see how effective a drug is. You only need to treat 22 cirrhotic bleeding patients with ceftriaxone to completely prevent one death.
Wow.
And you only need to treat 4 patients to prevent a severe, life-threatening infectious complication.
An NNT of 22 to prevent a human death. That is a colossal, indisputable mortality benefit. Compare that to the PPI, which we spent the last half hour establishing, has an overall mortality benefit of effectively 0. It is night and day. Ceftriaxone is the ultimate VIP drug. It absolutely demands that IV line. Okay, so the antibiotic is priority 1 for cirrhotics. What is priority number 2?
Priority number 2 is a class of drugs called somatostatin analogs. The most commonly used one in the ER is octreotide.
Okay, let me guess the mechanism here. If the problem is too much pressure blowing out the pipes and we need to stop the bleeding, is this a drug that just tightens the plumbing? Does it clamp down the blood vessels?
You are hitting on the exact physiological mechanism.
Oh, perfect.
You give octreotide as an initial 50 microgram bolus, and then you follow it with a continuous infusion. What octreotide does is cause potent, targeted vasoconstriction of the splanchnic circulation.
What's the splanchnic circulation?
The splanchnic circulation is the entire network of blood vessels that feed the stomach, intestines, and liver. Octreotide physically clamps down those vessels, dramatically reducing the raw volume of blood flowing into the GI tract.
That makes total sense.
As a bonus, it also suppresses the secretion of gastric acid and digestive enzymes.
So it is literally turning down the main water valve to a leaking pipe in a house. It reduces the pressure so the clot has a chance to hold.
That's exactly right. Now, to be fair to the data, a 2008 Cochrane review found that octreotide may not have a massive, clear-cut, standalone mortality benefit in all patients.
Okay.
But it makes profound physiological sense, and it has been proven to help prevent rebleeding in both variceal bleeds, those swollen burst veins in cirrhotics, and in nonvariceal bleeds, like our standard peptic ulcers.
Right.
It actively, mechanically reduces the pressure in the bleeding system, so it absolutely earns its place as a high-priority intervention in the critical minutes of resuscitation.
Excellent. So we have
All right.
ceftriaxone saving lives by preventing sepsis and cirrhotics. That's number 1. We have octreotide acting as the main water valve shut off to reduce pressure. That's number 2.
Right.
What takes the bronze medal? What is priority number 3?
Priority number 3 is the prokinetic agent, and the drug of choice here usually surprises people, erythromycin.
Wait, Erythromycin. Isn't that the pink bubblegum-flavored antibiotic they give kids for strep throat or ear infections?
Yes, that's the one.
Why are we giving another antibiotic?
It is an antibiotic, yes. But in this specific critical context, we are absolutely not using it to kill bacteria.
Then what are we using it for?
We are exploiting a very specific, fascinating side effect of the drug. Erythromycin is a motilin receptor agonist. It binds to motilin receptors lining the gastrointestinal tract and forces the stomach to initiate powerful, highly coordinated muscular contractions.
Wait, really?
Yes, it dramatically, rapidly increases gastric motility.
Okay, so it makes the stomach squeeze really hard. Why is that a VIP move during a massive hemorrhage?
Put yourself in the shoes of the endoscopist who has been called down to the ER at 2:00 a.m.
Okay.
They are about to push a tiny fiber optic camera down the patient's throat to find a microscopic bleeding artery. But right now, the patient's stomach is entirely filled with dark, thick, congealed blood clots, maybe undigested food, maybe black coffee ground material.
Right.
If the doctor goes in right now, they can't see a single thing. They're swimming blind in a sea of red sludge. They can't find the ulcer, they can't clip it, they can't burn it. The procedure is a failure.
Right. They can't fix what they can't see.
Exactly.
Yeah.
But if the ER team gives a 250 milligram IV dose of erythromycin exactly 30 to 60 minutes prior to the endoscopy, the stomach violently and vigorously empties itself. It pushes all those obscuring clots and blood down into the lower intestines.
That is brilliant. You are using the drug as a chemical broom to sweep the stomach clean before the camera goes in.
Chemical broom is the perfect term for it, and the evidence backs it up beautifully. A major meta-analysis of 4 randomized trials show that using erythromycin drastically, significantly improves the endoscopist's visual clarity of the gastric mucosa.
Because it's clear of all that junk.
Yes, because they can actually see what they are doing clearly on the very first try. It decreases the need for repeat endoscopies, it shortens the procedure time, and it ultimately decreases the overall need for blood transfusions because the bleeding is stopped faster.
That is amazing.
It is a highly effective, highly practical intervention that directly, tangibly alters the procedural outcome.
Okay, so let's recap this powerhouse lineup. We have ceftriaxone preventing fatal sepsis. We have octreotide clamping down the blood flow. We have erythromycin acting as the chemical broom to ensure the surgeon can see the target.
Yep.
Given all that incredible utility, where exactly does our famous, ubiquitous, hospital-mandated proton pump inhibitor fit into this hierarchy?
Priority number 4, the absolute undeniable afterthought of the resuscitation.
The afterthought.
It should only be given as a simple, intermittent IV push bolus, never a drip, and only after the patient is hemodynamically stabilized, the airway is secure, the massive blood transfusions are running, and the true VIP meds are already in the system.
And before the scope.
Honestly, giving it pre-endoscopy, you are mostly just doing it to keep the consulting gastroenterologist happy because they expect to see the order in the computer chart.
I want to speak directly to you, the listener, for a moment. If you work in healthcare, or if you ever find yourself advocating for a loved one in an ER, I want you to appreciate how completely, staggeringly inverted standard medical practices compared to the actual clinical evidence we just reviewed.
It really is upside down.
If you walk into almost any emergency room on Earth today during a GI bleed, the entire medical team will hyper-focus almost obsessively on getting that continuous PPI drip hung immediately. It is viewed as a life-or-death absolute necessity.
What's the very first order entered?
Yeah, we've just spent the last hour meticulously proving that it does little to nothing to change the patient's actual fate, and tying up the IV line with a continuous drip is biologically and mathematically useless.
Completely useless.
Meanwhile, in the chaos of focusing on that useless PPI drip, the medical team risks delaying or completely forgetting the real interventions. The antibiotics that stop sepsis, the prokinetics that clear the stomach, the interventions that actually statistically alter human outcomes and save lives are pushed to the background. We are majoring in the minors.
It is the ultimate textbook example of availability bias, defensive medicine, and institutional momentum. We do what we have always seen our mentors do, rather than what the cold, hard data demands we do.
All right, we have covered an immense amount of ground today. Let's wrap up this deep dive and hit the core takeaways one last time so they really stick. Number 1, proton pump inhibitors given before an endoscopy do not save lives, they do not prevent surgery, and they do not reduce the need for blood transfusions.
They merely paint over the rust and make the stomach look slightly better for the doctor.
Number 2, after the endoscopy, once the ulcer is mechanically clipped, PPIs do help significantly reduce rebleeding, but they still do not clearly improve overall mortality.
And we must always keep that bizarre Asian versus Western genetic mortality paradox in mind when we prescribe it.
Absolutely. Number 3, ditch the continuous IV drip. It is a waste of a precious 5E line, a waste of nursing time, and a waste of money. The biology of the stomach proves an intermittent bolus push is entirely 100% non-inferior.
Just a twice-a-day push.
And finally, number 4, reprioritize your emergency resuscitation. Put the truly life-saving antibiotics, the vasoconstrictors, and the chemical brooms at the absolute front of the line, and leave the PPI for last.
It requires a complete paradigm shift in how we approach this emergency. And, it leaves us with a final lingering thought to mull over, something that extends far, far beyond just the world of gastroenterology or medicine.
What's that?
Look at the sheer unstoppable inertia of standard practice. We have Cochrane reviews dating all the way back to 2010, proving that pre-endoscopy PPIs do not improve clinical outcomes. Yet the practice remains universally widespread and unquestioned today.
It's everywhere.
It raises a fascinating and honestly slightly unsettling question for you to explore in your own fields of expertise, whether you are in business, engineering, education, or aviation. How many of our standard operating procedures, our daily unquestioned habits, are designed simply to make the practitioner feel like they are doing something useful and in control, rather than actually changing the meaningful outcome for the subject?
How much of what we do every day is just painting over the rust? That is the profound question we leave you with today. Thanks for joining us on this deep dive.